a lot of them have coronary disease. And what actually we know is that patients who have diabetes have a 4 times higher risk of cardiovascular mortality. So that's why we have this great interest in this field. If you look at the graph on the left, and you look at the survival prospects of patients with diabetes, these patients, if they don't even have a history of MI, have as bad a prognosis as somebody who has had a heart attack before. So diabetes patients are as good as patients having a history of heart attack. That is how high risk they are. And of course, if a diabetic patient also gets a heart attack, then they fall into the red line, which is really the poorest prognosis patients, which means that the cumulative risk of, say, over 8 years, more than a 50% chance they're going to have a bad outcome. So why does diabetes affect coronary artery disease? I think a lot of you are endocrinologists, so you know that it exerts a problem with the endothelial function, so the cells are more permeable to atherosclerotic progression. There's also a degree of chronic inflammation, and that actually helps the formation of foam cells in the lining of the coronary arteries. And diabetes patients also have significant dyslipidemia. In fact, if you look at a significant proportion of them, when you look at their LDL particles, they actually have a higher proportion of patients having what we call small LDL particles, which are the highest risk atherogenic particles that can cause coronary disease. In addition, diabetic patients also have shared risk factors. So many of them do not have just diabetes alone, they also have problems with lipid problems as well as high blood pressure. So remember, you're not just targeting the patients with glucose control, you have to target the entire patient, the entire spectrum of diabetes, high blood pressure, and cholesterol. So we call this the 3 highs in many countries. So one of the interesting things that we get to see every day is patients with diabetes coming to the clinic asking us to screen for coronary artery disease. And the strategy that we adopt actually is a little bit, I would say, individualized. So if you look at this study that was conducted some years ago, this is the DIAD study. This actually looked at about 1,000 over patients with type 2 diabetes over a median period of 7 years. So they actually have diabetes for at least 7 years. And these are patients with no symptoms at all, just basically diabetic patients with no symptoms. And you subject them to a screening test, something called myocardial perfusion imaging, where you can inject isotopes in these patients to look at whether they have coronary artery stenosis. You will find that in this asymptomatic group, 22% of them will have blockages or significant ischemia. So this is what we call the concept of silent ischemia. Patients with diabetes, no symptoms, but actually 1/5 of them actually have ischemic heart disease. And what else do we know is in this group of 22% of patients, about 6% of them actually have very severe ischemia. So if you screen broadly, you will see that a significant proportion, about 5 to 6% of them will have serious ischemia. But what is the outcomes if you were to compare those who are screened versus those who are left alone? And actually, we look at it over long term, because you are not screening high-risk patients, you're screening everyone. This strategy of screening did not translate to a significant improvement in mortality outcomes. But this is because we are still unable to identify the highest risk group. In fact, in this study, we look at a post-hoc analysis in the patients that you detect very severe ischemia on the myocardial perfusion scan. They have a 6 times higher risk of coronary events. So if you do detect these high-risk patients, you can actually save them. So perhaps, maybe you think myocardial perfusion imaging is an older technology, and now we all have the CT coronary angiogram, which is a very widely used test. And it is factor 64 trial. This is actually a trial using a 64 slice CT scan. Of course, now we have moved on many generations to the highest kind of resolution. But this factor 64 trial is a very interesting study. This randomized 900 older patients to a group of patients where you just do regular treatment. These are diabetic patients, or what we call high-risk diabetic patients. These patients would have to at least have diabetes for a duration of 3 to 4 years, or 3 to 5 years. And then you screen them with either a CT scan or what we call neutral therapy. And again, quite similar to the myocardial perfusion scan, you will find 6% of these patients who have very significant chronic disease that requires things like PCI or they will require CABG. But if, of course, if we screen these patients, we will find that actually about 70% of them may not have too much of a significant disease. So it's really trying to identify which patients to screen. We need to find out still which are the highest risk patients. So the takeaway from this trials that we have at the moment is that just by looking at the patients alone, it's not so easy to tell which patients actually have silent ischemia. You have to use, of course, the ASCVD risk calculators, but that is one option. You can look at the patient's age as well. And finally, you can look at the duration of diabetes. So if you have a high-age patient who have a long duration of diabetes, especially patients on insulin, perhaps these are the group of patients you should be screening them more carefully. If you do pick up these patients, I told you 6% of them will have serious ischemia, then you will have to treat them aggressively. So you need to give them, of course, optimal medical therapy, but if they meet criteria for revascularization like an angioplasty or CABG, then you have to treat them accordingly. Recently, there are some more data on another form of screening called CT calcium score. And if you have a diabetic patient asymptomatic and have a CT calcium score that's elevated, perhaps this group of patients, you should also consider treating them with aspirin. Because in this group of patients with a calcium score of more than 100, they have a 3 times higher fall risk of developing chronic event. So let's look at patients now who have established chronic disease. We're talking about screening, so we're going to move on to what we call secondary prevention. So patients already have developed chronic disease. You have heard a lot of the speakers give talks today about the very important role of lifestyle-related changes, and we can't emphasize that more. So you have to look at patients' dietary, need for dietary changes, exercise ability as well as exercise activity, reduce smoking, and of course now you know weight management, which includes physical therapy as well as pharmacological therapy. So in these patients who already have established coronary arteries, that means you already know on CT scan or an angiogram that they have coronary disease, these patients will require antiplatelet therapy, either in the form of aspirin or clopidogrel most commonly. They will have to have optimized cholesterol therapies, very targeted treatment of the blood pressure, as well as optimize their glucose control. So you will know that the HbA1c targets, as recommended by the American Diabetes Association, would be to try to achieve a 7% target, but in patients who is prone to, say, hypoglycemic attacks, then perhaps a less stringent target can be considered. And why this is so is actually embedded in many of these clinical trials, which have seen that both cardiovascular events and cardiovascular mortality forms a J-curve if you look at the ranges of HbA1c. So of course, as you go higher with your HbA1c, you do not control the sugars well, the mortality and the risk of myocardial infarction goes up. But if you go too low as well, if you induce significant episodes of hypoglycemia, say if you go to very low levels in high-risk patients, perhaps if you look at this J-curve, there's also an increased risk in these patients where the glucose becomes too low. So there is actually a perfect range. That's why this is called a J-curve. You want to try to get the patient in the lowest risk in the perfect range of the HbA1c. Many of you in the audience would be diabetologists, so you have a lot of experience in the utilization of these medications, the SGLT2 inhibitors, as well as the GLP agonists. So I don't want to talk too much about the details, but these would be the two most important medications in diabetes that also have significant coronary and cardiovascular outcomes. Now, of course, the SGLT2 inhibitors, there are already so many trials and multiple meta-analyses which show that if you use these agents, they are certainly better than just placebo, and they improve significant in patients' cardiovascular risk as well as especially CV mortality. And also in the GLP-1 agonist, in this group of trials that you see here, at least in the LEADERS trial, there was a 22% risk in cardiovascular death. So there is clinical evidence that utilization of these oral GLP agents can translate to good cardiovascular outcomes. What about lipid management? If in general, we have been moving the bar lower and lower. So in patients who have established coronary artery disease at high risk, for example, you really want LDL to be low. So less than 55 milligrams per deciliter. But also remember, these patients with diabetes, many of them have actually small LDL particles. And even if their LDL looks normal, perhaps you should check the LDL particle size or the ApoB levels. And in this group of patients, you should also target to lower the ApoB and non-HDL levels to range. Because if you just look at LDL, in some patients you may be under-treating some of these patients. High-risk, small particle LDL. Blood pressure, you've heard the targets, it's just easy to remember. You must achieve a blood pressure of less than 130 over 80 millimeters of mercury. I want to point out also in diabetic patients, these are actually very unique features that we see in diabetes. So this is a very, very interesting trial. We have some time you can actually read. This is actually a trial on a Danish group of patients with diabetes. This is a very large observational study, 140 over 1,000 patients in Denmark, surveyed over a very long period of time, and plotting the risk of cardiovascular risk against age. So it's quite easy to understand the curves. So as you get older, obviously your cardiovascular risk goes up. So you have the blue curve and you have the red curve on the left. And this is, the left picture is for women and the right picture is for men. So you can see as time goes up, from left to right, the curve goes upwards in an exponential curve. So you know that as patients get older, obviously, the risk of heart attacks, poor outcomes increases. Then you plot that. So the blue curve is what we call the patients with no diabetes, the general population. And you plot the diabetics, the curve is on the left side, so it's the red curve. So you can see that in diabetic patients, all the bad things that happen in the general population happens 1 decade earlier. So if you see the patients who are the women, for example, if they have diabetes, your patient is 10 years older. The risk happens at 10 years younger, if you want to think of it that way. And in men, they are 12 years older. So remember, you want to target these patients because their risk starts earlier. The second thing about diabetics is that a lot of these patients have dysfunction in their peripheral nervous system, and it includes also the nociceptors in the heart. So some of these patients, they may not present any symptoms. That's why I told you that 22% of them have silent ischemia. That is one of the major challenges that we have. So patients can present with no symptoms, or they can present with what atypical symptoms. One of these atypical symptoms, they could have epigastric discomfort, they could have some jaw aches, they could even be just short of breath or dizzy, rather than presenting with the classic angina. And what we find is that even in the patients who present with atypical symptoms in these diabetic patients, their risk is just as high as anybody that presents with angina. So remember, if your patients demonstrate atypical symptoms, do not brush them away. Diabetics are very famous for having very atypical symptoms. So you need to treat them just as aggressively. And lastly, as an interventional cardiologist, this is one of the angiograms of one patient. And actually, this is an angiogram of a typical patient with diabetes, poorly controlled with insulin therapy. And this is what we call the most scary kind of angiogram because they don't have a single discrete area of blockage that you can treat easily. The whole artery is all full of cholesterol plaques, and they look like strings. There's no real normal segment anymore. The whole artery from the top of the artery to the tail of the artery are all filled up with cholesterol plaques. And what is the challenge of these string-like arteries where everything is blocked is that all the revascularization strategies that we know of, coronary angioplasty or CABG or bypass, they do not work well in these patients because they are already so diseased. So we are trying not to miss the boat by treating these patients earlier on. So that's why I told you they are all 10 years older. You need to catch them earlier on. So as an interventional cardiologist, we treat patients with coronary stenosis with coronary stents. So coronary stents are just basically scaffolding structures that open up the artery, pushes all the plaque to the side, and try to restore flow locally. What is the main challenge of these stents is that even though these stents are bio-inert and compatible, but the minute you put a metal stent in a patient with diabetes endothelium, you get an increased risk of what we call restenosis. Restenosis just means the stent gets re-narrowed over time. And they can be re-narrowed for two reasons. One is that there is increased risk of cellular hyperplasia. The cell itself becomes more aggressive and it forms like a scar within the stent and it blocked off the stent within the first 6 months. And the second thing is because they are also very pro-protogenic. They're very pro-protogenic. Okay. So because the diabetic patients are very pro-atherogenic, again, cholesterol can also deposit again in these arteries. And diabetes patients with insulin are at 1.6 times higher than the regular patients of developing this kind of restenosis. This is the worst kind of situation. You put in a stent, 6 months later, again, the patient comes back. So again, what can we do to prevent this? We can try to improve the patient's HbA1c because it's been shown, again, like a J-curve, if the patient's HbA1c can be kept tight, your restenosis risk can be reduced. So what other strategies do we have as interventional cardiologists to treat patients with diabetes and bad coronary artery disease? So one of these things that you've heard of quite frequently is that, we always put stents in patients with blocked arteries, but we are also nowadays conceptualizing treating some of these patients with what we call a drug-coated balloon. So a drug-coated balloon basically is a balloon that has outer part of the balloon has a chemical, usually drugs like sirolimus, for example. They actually act to produce these kind of chemicals onto the surface of the artery and try to reduce the risk of restenosis without having to implant a stent. Because you remember these patients' arteries are already so tiny and small. If you put a stent inside some of these arteries, it creates also an additional reduction in the space of the arteries. So people are exploring other techniques of using drug-coated balloons. So in this basket small 2 study, which actually enrolled patients with both diabetes and non-diabetic patients with very small blood vessels, they looked at whether implanting a stent was better or implanting using a drug-coated balloon where you don't implant any foreign object, which is better. So in the non-diabetics for small vessel disease, not much difference between whether you put a stent or whether you do a drug-coated balloon. But in diabetics, in patients with small vessels, in some cases, putting a stent will increase the risk of what we call target vessel revascularization. It's the chance of you having to come back for a repeat procedure. Whereas those who use the DCB or drug-coated balloon seem to have slightly lower risk in the very small narrow artery. So perhaps the drug-coated balloon can be a strategy for some of these patients. And in another registry, the same thing is seen. Patients, despite treating them with sirolimus-coated balloons, they although were better, but they still have a higher risk of target lesion failure. That means the chance of them coming back is still going to be higher if they have diabetes. What about stents? Are there any new changes in the technology of the stents that we have had in the last 20, 30 years? So remember, there's this constant fight about using different stents with what we call polymer-free, where they don't induce inflammation in these arteries, which are already inflamed by diabetes. So this is one stent that is trying to conceptualize a different way of treating these patients. Though what's new is that in these patients, the stents are carved in these stents are carved very small little reservoirs where they put in antilimers, and this is really actually sirolimus mixed with some fatty acid, and allow the fact that these stents do not have any polymer, and allowing the drug to go directly to the cell wall. And in addition, they coat these stents with a special coating of carbon, and this is supposed to reduce the risk of inflammation. So we are still evaluating these unique stents for diabetics, but certainly when we compare in this reservoir trial, this particular kind of stent versus the regular stents in patients with diabetes, the rate of target lesion revascularization is a chance of coming back again for a narrow stent appears to be slightly lower in this very small data set. But we still need to look at more data to see whether this truly is going to be useful. So remember, we still have the option of bypass operation. So if the patient has very, very complex diffuse disease in diabetic patients, there's still very good data for some patients who can do bypass. So this is a patient of mine that has what we call triple vascular disease. So we did the coronary angiogram for this patient, and you can see the LAD, the circumflex, and the RCA. And this is the normal reference, so you can understand what a normal artery looks like. And if you look at the bottom half of this picture, you will see that neither of this picture is basically no arteries at all. All three arteries are totally damaged, totally destroyed by cholesterol. And therefore, in this patient, there wasn't a stent option, and the patient had to undergo a coronary artery bypass, which can give patients good results as well. But unfortunately, there will still be some patients that despite bypass, it does not work for them. Remember I told you the strings, these patients have very diffuse small vessel disease. If you bypass a very small vessel where the flow is not very good, because below the bypass segment there's still disease, the grafts will fail. So the patients will have a bypass, yes, they will be okay for maybe a year, but after a couple of more years, the graft will fail. And these patients will come back to square. So remember, it's about treating the patients early, not just depending on bypass or DCI as a criteria. So what really happens in these patients if you evaluate them and you find that you've given the best medical treatment, you will look at the angiogram, and unfortunately they cannot undertake PCI or angioplasty. And you send them to a surgeon, and the surgeon says, I'm sorry, the patient's artery is too terrible now, and I cannot do bypass. And we actually see these patients. This occurs in maybe about 5 to 6% of patients whom we refer for diabetes treatment for bypass. What do we do with these patients? These patients will have refractory symptoms, angina, heart failure. And so this is a new concept of treatment in some of these patients who have what we call no hope. No hope meaning they have no hope of getting more outcomes for medical treatment alone. So this is what we call coronary sinus reducer. So when we implant these devices in the coronary sinus, we intentionally narrow down the size of the coronary sinus. And what this does is it increases the venous pressure within the coronary venous system and redistributes the blood flow within the heart muscle. And this is still very early days. There's already one study that shows that this implantation can reduce episodes of daily angina in a group of patients that cannot undertake PCI or undertake bypass. And this is called the COSIRA-2 study. And this will come up maybe in the next 2 or 3 years to see whether this will be a solution for some of these patients. So I'd like to conclude again that diabetes is a truly problematic risk factors, and they really affect patients, and we really need to pick them up early. That's why early diagnosis, I cannot emphasize more. You have to think of these patients as being 10 years older. Do not miss the boat. And finally, of course, the collaborative care of these patients involves not just the cardiologists, but also diabetic doctors, endocrinologists, the kidney doctors, allied health, as well as the inventors and the scientists that work continuously to try to treat these patients. So with that, thank you very much for your attention.
He will talk about diabetes and heart disease. Where is
Good morning. Firstly, my name is Xuan Hong. It's a Taiwanese name, so it's hard to pronounce because I was born in Taiwan. And on behalf of others, as well as Pathway, I'd like to thank the organizing committee for inviting us to this conference. I'm very encouraged. It's a mixture of endocrinologists and cardiologists. Okay, good. Usually at the beginning of a talk, we'll talk about conflict of interest. Most speakers internationally will say that. My conflict of interest is that my wife is an endocrinologist. I have diabetes since 2003, and I do not let my wife control my diabetes, because then she'll say you cannot eat this and you cannot eat that. Alright? So that's my conflict. your interest. But coming back, my primary training is that of a heart transplant, heart failure, and also in 2003 to 2006 when I was posted in Cleveland. Those were the early years we started playing around with 3D imaging, strain, and as well as imaging for the mitral valve clip. So the first 10 in men was done during my time when we were a fellow in Cleveland, before the Everest trial. Now, many of the speakers have talked about, so firstly I'd like to thank my mentors. These were my different mentors. Some of them specialize in some of them are electrophysiology, some of them hypertrophic cardiomyopathy, and some congenital heart. Over in Cleveland, we try to work with each other to understand how to develop new imaging techniques to serve the purposes. So they were my inspiration. And then this is my team. So I'm the founder of Asian Heart and Vascular. I started in Parkway 18 years ago. So I'm looking forward to beginning a new chapter as a professional golfer and watch football all the time rather than be a cardiologist. So we work as a team whereby when the patient comes in a problem, not necessarily it might be coronary artery disease, but it's a mixture of AF, heart failure, and we try to discuss as a team. And obviously, from the slide that I'm a Liverpool supporter, so don't be offended if you are a Man U supporter. Now, I'm a golfer, as I said, so a lot of times we cardiologists face, especially the non-interventionists like myself, we have a lot of guidelines to follow. So do you listen to a European guideline or do you listen to the American guideline? Oftentimes, they like to agree to disagree. Alright? So just on the heart failure scene alone, you can see that guidelines keep coming up, and it's very tiring to read guidelines. How many of you all read guidelines regularly? Okay, I hate guidelines, okay? But for the purpose of talk, I have to give all the guidelines up to September 2025. So this is a guideline that differs between Europe and America. And likewise for the valvular heart disease guideline, as I was preparing this talk for this conference, you have, again, 2020, and then American come out with another one, and Europe, we thought that they would agree with the American in 2021, and this year they come out with another new guideline for valvular heart disease. And on top of that, we now have also to read the diabetic guideline, ADA guideline, American Heart Association, and just not long ago, obesity guideline, and European guidelines. So what do we do? There are a lot of information. So, too many guidelines cause us to be confused. How do we manage a patient? But since we agree to disagree, we need someone to simplify the guideline. And you can't agree, then Donald Trump will probably help. Okay? I'll talk about Donald Trump later. Alright? He's not my idol, but he does a lot of good things though. Today, my main topic focuses on 6 areas. So my job is to try to crystallize, summarize some of these guidelines so that it will help you perhaps in the management of patients. First, we had the revised heart failure classification in 2021. Alright? Secondly, the topic about early detection, just like Dr. Ekka, Professor Sam, early detection leads to early implementation of effective treatment strategy. The importance of SGLT2 is already much highlighted in this seminar, and you all will know it better than I do. There's this new class of heart failure called heart failure improved ejection fraction. In the past, we will call that heart failure recovered ejection fraction. What are the challenges when we face with this group of patients? Fifthly, I'll talk about the advances in the interventional aspect of heart failure, and lastly, briefly about weight loss. As mentioned, men and women with diabetes will die at least 6 years earlier, but if they have heart problems, then tend to to 12 years earlier, and even earlier we have diabetes and chronic kidney disease. That has been covered. A lot of times we talk about micro and macrovascular complications, but we don't die much from microvascular complications. Most of the time in the past we have focused much on the glucocentric, trying to lower sugar, by thinking that when we lower sugar, we can lower the event of death. But truly, lowering the sugar, yes, does help a lot in the microvascular complications. But in terms of cardiovascular complications, it does moderately lower, but it doesn't become. Let's get our focus correct that most diabetic patients, at least 70 to 80%, will die from cardiovascular disease. How can we stop the macrovascular, issues when we manage diabetes? And as we know, in recent years, worldwide, there's an increase in heart failure. What happens when you have heart failure? Once you get admitted, the likelihood of you getting readmitted to the hospital is 1 in 4. And 1 in 2 patients will get readmission to hospital within 6 months. So the lifetime risk of diabetic patients developing heart failure is increased to at least 24%, 1 in 4. All right? So what do we do with them? A lot of focus in the past, this is the 2023 European Guideline for Management of Cardiovascular Disease in Diabetics. A lot of focus in the past has been on cardiovascular disease. That's correct. So we talk about ASCVD, how do we manage hypertension, lipid, and all these things. But actually we realized that actually at least 22% of diabetic patients do have heart failure. And the prognosis is worse when it's combined with heart failure and chronic kidney disease. So now how do we tackle this cardiometabolic problem? We would think that diabetes and heart failure are closely interlinked. Diabetes will predispose to heart failure, and heart failure patient is the insulin resistant state, they are more likely to develop diabetes. But truly, they do not exist on its own. There are many partners in crime. As we grow old, we develop hypertension, obesity, chronic kidney disease, and all interlinked to add to the increase in mortality. When we first define heart failure, why do we need a definition? If we don't have a definition, then we do not know when to implement the evidence-based medicine. From 1933, when heart failure was first described as the heart failed to discharge its contents, there's a current interpretation is heart failure with reduced ejection fraction. And many a times, when we look at the symptoms, we are not very specific. So in the 2016 classification, they do not include, they don't have objective measure of increased feeling pressure. So the latest guideline define heart failure as a clinical syndrome with symptoms and signs caused by structural or functional and supported by elevated cardiac markers or objective way of assessing pulmonary artery pressure. So this is the new guideline. Okay. Together with new guideline, we also, there's a new staging. In the past, we call it A, B, C, D, and we call them at risk, stage A, B, C, D, but now we call them at risk and pre-heart failure. This is to allow us to understand that before the patient are symptomatic, if we can detect them early, then effective treatment could perhaps be implemented to prevent heart failure. And then there's a stage C and D, of which stage D we call it advanced heart failure. Alright? This group, you must be careful about the prognosis because we know that the outcome could easily be less than 50% survival in 1 year. So 1 in 3 Americans have stage A heart failure. But we wouldn't want to call them heart failure because then the insurance might not agree on the terms that we use. We just call them by primary disease, diabetes, hypertension, etc. But if we fail to detect, and most patients are asymptomatic, then we can't implement effective strategy. The only problem I have we have with this guideline of this pre-heart failure. In pre-heart failure, you already have structural heart disease abnormalities, right? They are asymptomatic. But how many patients come to you, their heart function can be 30%, but they don't have symptoms because they don't exercise. So this idea still of symptoms is very difficult to justify because certain treatment is indicated in stage E, C, but not stage E. All right. Now, the new guideline recognizes that this is a moving target. Heart failure will be active. There will be periods where the patient feels better. All right. But then there were periods of exacerbation called worsening heart failure. Worsening heart failure doesn't mean you get admitted to hospital. Worsening heart failure could simply mean as simple as you having to increase the diuretic dose. These patients are at risk. Okay? There's no such thing as, once you have developed symptoms, there's no such thing as stable heart failure. Because for all these patients, you can always try to do better. The key thing is, when you first saw a patient and say the heart function is 45% or 30%, do they stay as 45% or 30%? Repeat assessment can tell you whether it could be improving from 30 to 45, or 45 getting down to 30, then you might need to take more action to optimize the treatment. So the guideline tells you that this is a moving target, heart failure is active, do not be too complacent. So no heart failure should be labeled as stable, and we are never going to negate the risk completely. One of the main emphasis is that of early detection, and we recommend that for diabetic patients, annually you do a proBNP and TROP-T as a marker. And where the patient can afford, you can test them for urine albumin to creatinine ratio. Now, the availability of the test making available allow us to detect all these asymptomatic at-risk and pre-heart failure so that we can implement the right strategy. So this has been upgraded to class 1 indication in the 2023 guideline. I can't move the slides. Yeah, so screening is available. There will be other patients where you might need to do a bit more screening. For example, those patients who come in with a familiar history and you really don't know what their prognosis is, some of them might do genetic testing. So we would recommend that for regular diabetic patients, yes, you do TROP-T and proBNP. For those who go into chemo, you do TROP-T and proBNP, TROP-T specifically. And for those people with any suggestion that they might have early kidney involvement, to do your UCAR, all right? So early detection will be implemented. There are not much guideline for pre-heart failure, but one thing, so you manage the hypertension and lipid according to your guidelines. But in the last few years, basically SGLT is the one that takes the limelight. It's not just used for at-risk, the diabetics at risk, and especially diabetics at risk with kidney failure, that's useful. And also, we have in recent years, in last 2 years, finerenone. I understand your price is not as expensive as Singapore. Most of the drugs are more than half the price less than Singapore. Right? In Singapore, our main problem is that the drug companies sell us with markup, a lot of markup. So diabetic kidney disease present in 40% of type 2 diabetes. And the risk of a new onset heart failure is higher in the diabetic with CKD than diabetes without chronic kidney disease. In fact, it will probably die more of CV mortality than die of end progression to end-stage kidney failure. And so, you cannot ignore this group of people. So very much what has changed in the last 3 years, is the finding the usefulness of SGLT2 across the entire spectrum of heart failure. And this is roughly from DAPA, CKD, and MPA-KIDNEY, which shows that there is a reduction in the progression to CKD as well as cardiovascular death. In particular, DAPA-CKD shows a significant reduction in heart failure hospitalization. Finerenone is as Professor Sam has mentioned, is a non-steroidal MRA, and it's been shown in patients with CKD to be able to lead to CV mortality reduction by as much as 14%, as well as 22% reduction in heart failure hospitalization. Now, that has resulted in these two drugs being recommended as class 1 in from angle of diabetologists or heart failure specialists, but we'll come back to this slide later.